Just recently, I came across this article with a very provocative title: Surgery, the Ultimate Placebo. Wow. When we talk about placebos, we're usually thinking of pills and tablets, maybe an injection. But surgery? The author of this piece, Dr. Ian Harris, a professor of orthopedic surgery in Sydney, Australia, is throwing out an inflammatory statement. He claims that more than half, over 50% of all operations, bring about their benefits merely by acting as placebos, a beneficial effect which cannot be attributed to the properties of the placebo itself. Here's a claim that really needs to work hard to convince me or anyone. Let's look at what the good doctor is saying. A patient is seen and diagnosed as having a condition that requires an operation for its cure. The surgeon comes in and confirms that the operation is needed. The patient undergoes surgery, and after a period of recovery and recuperation is back to routine. The natural assumption is that the operation was the reason. But, says Dr. Harris, this is a false assumption. There is no scientific proof on most occasions for jumping to this conclusion. The resolution can equally well be the result of one or even both of two mechanisms. It's well known that many disorders are self-limiting. The body can heal them by its own mechanisms without any treatment or any intervention from the outside. The placebo effect is a well-documented phenomenon whereby just the act of carrying out any intervention, being seen to treat, results in resolution of the complaints. Dr. Harris points us to a systematic review, an in-depth research of all known publications, which indicated that in 50% of all operations, the surgery gave the same result as a placebo. Now, that should wake us up. When we say evidence of efficacy, what exactly are we talking about? The randomized controlled trial is the gold standard of evidence in medicine. Any proposed intervention is compared against a control by random allocation. The outcomes are put through rigorous statistical analysis to show that the proposed method is superior or only equal, maybe sometimes even worse. The sum of such studies forms the evidence base of support. Dr. Harris states that there is none or only weak evidence for a large number of surgical procedures. If this were true, there are two fundamental issues to handle. One, vast sums of money are being spent performing operations, many of which have no proof of benefit. And two, even more worrisome, the ethical aspects of offering procedures that carry significant risk, sometimes even death. Confronted with all this, surgeons usually respond with, "In my hands it works." Surgeons consistently rate the effectiveness of their procedures much higher than those on the receiving end, the patient. When outcomes are objectively analyzed using quantitative tools like the SF-36, the findings often run counter to beliefs. And not to forget, the common fallacy of equating correlation with causation. Birds sing when the sun rises. It's incorrect to conclude that birdsong makes the sun rise. So back to where we started. Is surgery merely a placebo? Let's start by evaluating Dr. Harris and his opinions based on a dozen criteria that I use to measure value. He does well on 8 of the 12 items. Coverage and accuracy reflect his own personal biases. The central question is one of the feasibility of putting his suggestions to work. There is a real risk of throwing the baby out with the bathwater. There is a long list of operations where surgery is useful and even life-saving. One is reminded of the professor who warns his class, In 10 years, half of all I have taught you will be proven incorrect. Problem is, I don't know which half. Without a doubt, surgeons must prove new surgical procedures to be beneficial in well-constructed and well-analyzed randomized trials. However, offering sham surgery as a possible choice in the randomization process could be ethically very troubling, but has been done in many studies. Dr. Harris brings up an important, troubling debate. Stay tuned.